morning, everybody. Welcome to Grand Rounds. We're back from summer break. I'm Jesse Powell. I'm in the medical education faculty here with the internal medicine residency. And I'm taking over for Liz Stevens as the host of this Grand Rounds series. And we've been off for 2 months, so this is our first lecture back. I hope you've gotten all your water slide amusement park adventures in and seen your summer cartoons, and you're back here for fall semester. I'm thrilled to see such a good crowd. And you're here for a good one. We have, as our inaugural fall speaker, speaking over the construction that's inevitably going on here at Prov, we have Audrey Curtis, who's here to talk to us about urinary incontinence. Dr. Curtis completed her medical school at the University of California, San Francisco. She then went on to do her obstetrics and gynecology residency at Kaiser Permanente in San Francisco and her urogynecology fellowship at USC. She currently serves as the urogynecology medical director for Legacy, and she's involved with the fellowship faculty at OHSU. She's on the Legacy Medical Group Governance Council, and she is a decorated and well-experienced speaker. She's treated us here multiple times at our Grand Rounds. I believe most recently she gave us a talk on bladder pain and UTIs. And we're thrilled to have her here with us. So please give a round of applause for Audrey Curtis.
So I know you don't have urinary incontinence problems if you went to water slides for for summer break, but I think that this is a great subject for primary care. Unfortunately, the statistics are really high of women that are experiencing urinary incontinence problems. We were joking just before the lecture. Usually the discussion is right as you're trying to get out the door. They say, oh, and by the way, could you give me a prescription for Depends? And like, how much of Pandora's box do you open up and talk about this? And so, so my goals for today are, one, to give you just the tricks to be able to get through that office visit and to know that you don't have to do all of this counseling. There's some really good resources. You should just get these women to physical therapy. So that'll be kind of the first point that we'll talk about for that basic evaluation. And we'll talk about the other things that are uniquely within your purview to work on. And then we'll talk about the great new options that exist. A lot of times there's just this historical belief that, well, there wasn't any much more to offer anyway, so I shouldn't refer them. There's nothing more to help with. And there really has been a lot of advances in the area of urge incontinence. So we'll talk about that. And hopefully you'll feel at the end of it just a little more comfortable with when she says I'm leaking, what to do about that. So the statistics are really pretty impressive, 25%. So this is urinary incontinence with a bothersome accident at least once a week. So this isn't just I occasionally leak, but this is a problematic accident at least once a week. 25% of young women, 44 to 57% of middle-aged women and postmenopausal women, and 75% of older women. And it's actually really challenging. It's one of the main reasons for admission to nursing homes, because family can no longer manage the incontinence that's happening at home. And the price and the cost of care is really expensive. I've always joked I really should have bought stock in Depends when I was going through fellowship. But $19.5 billion a year in expenses to care for incontinence in the United States. And it just has all this ripple effect. There's all the expense of the pads and everything else, and then women can't be cared for at home, and so they go into care facilities. And then they start getting all this vulvar skin problems from the pads, diaper rash and skin breakdown, and then that becomes challenging to deal with, and it's just this snowball effect. And women feel that this is a huge impact on quality of life. There's a recent survey done on, if you got these diseases, which would you consider worse than death? Like, kind of rank the medical conditions that you're most scared of. And fecal incontinence always makes it into the top 3. I'll reference that just briefly today. But urinary incontinence makes it into the top 10. So while we think, well, really, I mean, there's a lot of medical conditions that you should really be more scared of, and they would be worse than death than incontinence. But to women, this is it's horrible. It's super life impacting, and oftentimes it makes women go to the point of being homebound if they just can't manage the incontinence because they're afraid to be in public with accidents and the odor and all of the rest of the problems. And it's largely silent. That's the biggest challenge. 8 out of 10 cases can be improved, but less than 50% discuss it with their provider. The tide is moving a little bit as we watch these national surveys that are done. A few more women are talking about it. It's still not yet at a Super Bowl, advertisement in the middle of halftime, right? But women, it is becoming a little more, there is more awareness, but women still have the feeling of, I go into the doctor and there's not much they can do. And so I'm hopefully you'll feel a little more comfortable with that. So why do women get incontinence? And I think it's important to understand there's different mechanisms of this. So at a very basic level, the muscle can have dysfunction. That big, balloon that blows on that's the bladder is the detrusor muscle. So there can be muscular dysfunction, as well as there are muscles around the exit tube or the urethra, right, that can have muscular dysfunction. There can be nerve dysfunction. The messaging is no longer correct between the brain and the bladder, and so the bladder just resorts to when we were in diapers, right, and it decides when and if it wants to go, and there can be support dysfunction. Now, we almost always blame most of it on this support, right? The bladder's falling down, she's leaking. We'll talk about why that's not true, but still ligaments and fascia after childbirth can predispose women to having incontinence earlier. But prolapse does not equal incontinence. The bladder falling down actually usually results in less leaking. And I'm always, talking with patients and using my hands. But if you think about the bladder as a big balloon and then there's the urethra, as the bladder starts to fall down, it gets kinked off. Prolapse almost always improves stress incontinence, not causing it. And that's another important thing to understand. If I go in and do surgery and fix the prolapse, if I don't think about incontinence, I'll make it worse. And even more important, overactive bladder or urge incontinence, those names are used interchangeably. We'll talk about that in a little bit. That doesn't make any difference about where the bladder's sitting. If it was having urge incontinence falling down, it's going to have urge incontinence up inside. It doesn't matter with the prolapse. Prolapse and incontinence happen commonly together, the same set of risk factors predisposed to both. So women often have both. But again, it's just real important to understand prolapse does not cause incontinence. If anything, it usually makes it a little bit better. So one of my patients sent me this card, urology department, can you hold? So let's talk about the types of urinary incontinence. And the most bothersome one is by far urge, can you hold? So urinary incontinence is just the complaint of any involuntary leaking of urine coming out when it's not supposed to. Stress incontinence is the one that is maybe more understood but not as bothersome. So that's sneezing, coughing, laughing, any exertion, jumping up and down, bearing down. That poor little exit tube, just the urethra can't hold on tight and urine comes out, sometimes a little, sometimes a lot. Urge incontinence is a problem with the detrusor muscle. That has to do with the main body of the bladder, right? As that bladder starts to fill up, that muscle says, I gotta go, I need to go, I wanna go, I'm going, and they don't have time to make it to the toilet. And oftentimes that muscle does that when the bladder's only a quarter full, a half full, so women will say, yeah, I've got this 5-star alarm, I go running for the toilet, and then only this little bit comes out, and I think, why did I have to run for that? So that is urge incontinence, and of the two, urge incontinence causes far more bother to women. So why do we care? The treatment of these is very different. As we go through this, that's what I want to help you understand. We treat these two differently, and so it's kind of important to figure out quickly what they are. And that history is usually not too hard to take, and if it is, you probably don't want to spend much more time on it, right? So I just quickly ask them, is this the problem with sneezing, coughing, laughing, or are you doing the potty dance, and do you know where every toilet is on the way home to your house, right? Or can you not get through the door without your bladder leaking before you can run to the toilet? And pretty quickly you can know if it's both. It is not uncommon for women to have mixed, to have both of them. And again, treatments are separate, so we got to work on both of them. And then I'll bring up just this last one, nocturnal enuresis, or involuntary loss of urine that occurs at night. Particularly if she is wetting the bed while she's asleep, that is just more challenging. No, that's kind of a red flag, and you need to get them referred. And that's probably not going to just respond to simple stuff. There's probably something neurogenic going on, as opposed to they just wake up 10 times a night to go to the bathroom. Now we're just still with urge incontinence, right? Their bladder only gets to quarter full, half full, and it says, you better go in. So they're up several times at night because they can't ever fill up to full to actually sleep through the night and not have to go to the bathroom. So again, if she says, I'm just wetting through pads while I'm asleep, just know that's a slightly different category. The other one that I commonly get, and it's not really in this types of urinary incontinence, is my pad's just always wet. I'm just leaking all the time. And it's kind of important to ask and say, do you feel the urine come out? The urethra has so many nerves in it that every time a woman leaks, she goes, oh crap, I just peed my pants. It's not, you don't miss urine coming out. And almost always if the answer is, oh no, my pad's just always wet and it smells like urine, right? But she doesn't actually feel an episode of, I just wet my pants, I feel the urine coming out. That's almost always vaginal discharge. Now it's really hard for me to convince them of that, and sometimes I put them through a trial with Peridium. I have them take azo over the counter. It turns the urine bright orange. We talk about, after you go to the bathroom, wipe off really good, go back 10 to 15 minutes later and wipe again, right? And then look at your pad. If your pad is turning orange between, really cleaning up after going to the bathroom and the next time you go, then it's urine loss. And then I'm looking for weird things, if it truly is. 99% of the time, it's not urine loss if she can't tell you, I had this sudden horrible accident where I leaked. So those are just the few nuances just to make you think, oh, that doesn't sound quite right. Just urine, my pad is wet and it smells like urine. There's always a little bit of urine left after wiping, right? Unless they have a bidet or they're going through an extensive cleaning up after every time. There's a little bit of urine left. That pad, if they're attempting to smell it, will always smell like urine. So that's not the differentiator of urinary incontinence. So let's talk a little bit about the predisposing factors. So these are the typical ones we think of: vaginal delivery and parity, all those babies cause me to leak, age and family history. And these are true, but let me tell you another statistic here. By the age of 60, the same percentage of women are incontinent that had babies and did not have babies. So babies simply make the incontinence happen earlier, but they are not the exclusive cause of urinary incontinence, particularly urgency incontinence, the one that bugs them the most. So just having no babies doesn't fix the problem of urinary incontinence. So obesity, chronic lung disease, smoking, and chronic constipation. These are ones that definitely cause it to happen earlier, and unless we can get through some of these, it can be very difficult to treat it. So particularly if I'm talking with a patient about wanting to go through surgery for stress incontinence, which we'll talk a little bit about, I will almost always, in morbid obesity, insist that she go through bariatric surgery first. The outcome is so much better if we can just deal with the obesity. And chronic constipation, if you don't ask about it, you kind of don't know that it's happening, and just continually bearing down against that pelvic floor isn't doing any gifts to it. And infections and medications, and we'll talk about those. Those are we always want to rule out a UTI. Sometimes the only symptom of a UTI as women get older is leaking. They don't have pain or burning. They've got urgency frequency with overactive bladder, right? That could sound like a UTI, but no burning. And all of a sudden they just are leaking, particularly if it's kind of acute onset. You always want to rule out infection as the potential etiology. And then medications, and we'll talk about which ones that are really helpful if we can change. Some medications can't be changed, but there's diuretics in particular. If there's an alternative option to treat the hypertension, we don't win against diuretics, right? Their goal is to get the urine out, so it's going to exacerbate it. Now the last two, so estrogen use is an interesting one. When women are doing oral or transdermal, systemic estrogen replacement therapy, it makes incontinence a little worse. If they do vaginal estrogen, so that's not systemic, right? That's not being absorbed in the bloodstream. That often makes incontinence a little bit better. And so estrogen is this complicated one, and we will use vaginal estrogen to help, particularly in overactive bladder. But don't put her on oral estrogen just to try and make her leaking better. But you don't need to take her off. It's not that big of a component. If she likes her estrogen, it's not making that big of a deal for the bladder. But again, estrogen's always just a little bit complicated. And pelvic surgeries, particularly if they've had previous incontinence surgery, it's kind of the one time where the symptoms no longer are as accurate. So when a woman comes in, she can almost always tell me, if I describe to her stress incontinence versus urge incontinence, she can tell me if she's got one, the other, or both, and she can tell me which is more problematic. If she's had pelvic surgery, I always know to question that history just a little bit. And pelvic surgery, prolapse or incontinence repair. So I'm not just talking about a hysterectomy. But if she's had both of those, I always just, in a previous incontinence or prolapse repair, I'm just thinking maybe her bladder isn't telling me the right story. So let's talk about drugs that cause urinary incontinence, because we'll go through some of the simple things that can help when she presents. So caffeine. Any version of caffeine, and even a little bit. And so women are always saying, well, but I only have half a cup of coffee, and I've had it all my life, and it's never been a problem before, right? I get a lot of that. Well, by the time it gets to the bladder, it's pretty concentrated, right? Because the kidneys have filtered out everything, so you've got a higher concentration in the bladder, and it doesn't seem to matter. A little bit makes a big difference. And so caffeine occasionally will be in medications they're taking for migraines, et cetera. So that's another thing to think about. Alcohol acts like a diuretic, diuretics. And sedative hypnotics, benzos can be problematic. And it's probably acting through a neurogenic mechanism, but sometimes it's just functional. We get sedated, and if they get sedated enough, they can't make it. ACE inhibitors, calcium channel blockers, those are not near as problematic as the diuretics. So just know in the scheme of things, if you've got to change it, get rid of the diuretic is the number one, but ACE inhibitors and calcium channel blockers can affect it. Alpha adrenergic antagonists, sympatholytics, not many women are on these necessarily. And opioids. So opioids are an interesting challenge. We will always see, it's why we see bladder dysfunction after orthopedic surgery. You're thinking, they worked on the hip. Like, why is the bladder not working, right? It's probably got the most to do with narcotics. So anytime one of my patients with borderline bladder dysfunction is going to be going through surgery, I have the discussion with her about what's going to happen with her bladder after surgery. And again, we believe it's related to the narcotics most of the time. So the ones that really I want you to focus on, it's not so much the benzos, but caffeine, alcohol, and diuretics. Those are the simple ones we can tell her about. And if there's an option to get her off of the diuretic, please. So transient causes of urinary incontinence, just like this acronym, but we'll talk about the ones that matter most. Diapers, but delirium or acute confusion, that one you usually don't miss. But UTIs, sometimes there's no pain, right? Sometimes there's no dysuria. Atrophic vaginitis or urethritis, vaginal estrogen. Pharmaceutical agents, we talked about those just the last slide. Psychological disorders, again, sometimes there just can be, these have to be pretty extreme, not run-of-the-mill depression. Excessive urine output, so diuretics. Excessive fluid intake, it's sometimes very enlightening when I get these voiding diaries to see how much women are drinking. That 8 glasses of water a day, and to not get dehydrated was kind of the worst thing ever perpetuated on women's bladders. Most of them have no need for that much, and I always laugh, you know, walking down the hallway with the big, huge water thing. I'm thinking, oh, you need to see me, you need to see me, you need to see me, because they're usually causing all of this problem. What goes in comes out, and that's a really hard conversation with women. They're like, oh no, it's not the same. I'm like, it is. I mean, what goes in comes out, so unless you're having a lot of diarrhea or profuse sweating, it's all coming out through the bladder, and that's why you're up so much at night, or that's why you're having trouble. And 60 to 80 ounces a day is all that's needed to not be dehydrated. And so if you think about that, you know, they're doing 8 huge glasses of water a day. They're not doing little 8-ounce cups of 8 glasses of water a day. So again, sometimes that can be really insightful just to ask about what they're doing with water. Restricted mobility, obviously, and stool impaction or even just constipation. So the ones to kind of focus on, remember about UTIs, remember potentially about that vaginitis. Think about the drugs, diuretics, 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 and we'll talk about caffeine too. But then if we've really got excessive urine output, is there anything that can be done about that? Is there ways we can mitigate that? Restricted mobility. There's only so much we can do if she can't get to the toilet, but having the discussion with family or the nursing home or care facility that she's in and doing aids like a commode next to the bed, et cetera, could be helpful. And then again, just don't forget the stool. So she comes in and she says, I've got incontinence, and you're thinking, oh dear, here we go, right? Again, I don't have time to deal with this. The most important question first is, does it impact her quality of life? A lot of women leak but don't care about it. And you don't need to care about it if they don't care about it. I mean, please open the door and give them the options if they do. But it's kind of a good quick thing is, are you using pads? If she's like, oh, no, I don't need pads for it. I mean, again, I then kind of ask, do you change your clothes 4 or 5 times a day? I mean, is she just not like pads and so she's just wetting through clothes and changing them a bunch? But if she's not needing pads at all, and if it hasn't stopped her from doing anything she loves to do, she maybe doesn't need a lot of help with it, other than a quick, what type of incontinence is it, and I have stuff to offer you if it becomes more bothersome. But really, the first question is, does it bug you? And how much? Like, is it impacting quality of life? And really that question, does she really want any help at this point in time? And I think just reassuring them, there are options short of surgery. Women have all seen the ads about mesh and incontinence, and we'll talk a little bit about that. So they're afraid that that's the only thing, and they don't want that. But I mean, you can just tell them, look, there's options we can do short of that. So if you want help, I've got some simple options with physical therapy and some behavior stuff I could tell you about. Or if you're doing fine, you just let me know when you're not, because incontinence usually doesn't go away magically, and it becomes more of an issue as women age. But again, that's the first question. Does it bug you bad at all? So, and then the next question is figuring out, like, is it stress or urge? So we talked about that. Is this the sneezing, coughing, laughing, or are you doing the potty dance, and do you know about every toilet on the way home, and you can barely get through your door? And you'll know real quickly, this is stress, this is urge, or maybe it's both. It's really good just to make sure, does she feel like she empties completely? And I always get nervous about this one because half the women answer this question wrong. If they have urge incontinence, you ask, do you empty their bladder? Say, oh no, I never empty my bladder. But it's not because they feel they don't empty their bladder. They're just sure that if they have to go back into the bathroom 30 to 45 minutes later, they must not have emptied their bladder, right? I mean, that's their conclusion. So you have to just be careful with that question. Not everyone's running out there with urinary retention, right? But if there is a feeling of true incomplete emptying, if she says, yeah, I sit there on the toilet and I know there's a bunch still left in my bladder, we got to figure that out. That's another problem. But again, if she just is convinced that because she goes to the bathroom 30 to 45 minutes later that she didn't empty your bladder, that's not urinary retention. And then think about those reversible causes. So that diapers acronym, just see if you can remember those. It was the infectious. Think about the UTIs. Make sure there's just not a ton of vaginitis. That's the issue with this. Think quick about the medications, like look at her list. Do I have her on a diuretic for hypertension, and could I just simply change that and make it an easy switch? And are there significant, compounding fluid intake issues that we could stop the 8+ glasses of water a day? And then again, think just quickly about the meds you've got her on and ask her, how much caffeine are you taking in? Because sometimes they go, oh yeah, 2 or 3 cups of coffee in the morning, and then I have 4 or 5 Dr. Peppers the rest of the day. It's like, oh, I got the answer. We have to change this. And then again, just think quickly about those diuretics and could you get rid of them? So the examination, kind of what's the minimal? I'm sorry, it really needs a pelvic exam. You can't get out of a pelvic exam with this. It doesn't have to be at that visit, but we just got to know. You'd be surprised at how awful some of those vulvas look from the diaper rash and those problems. So she does need a pelvic exam, or send her to the gynecologist to get a pelvic exam. She hasn't had one in a while. Someone really needs to look at that vulva. And then we kind of assess other things too, right? Almost always they've got prolapse, and I'm having that discussion and explaining it didn't cause it. While I'm doing the pelvic exam, I have her do a Kegel. My fingers are in there, right? I just say, okay, do a Kegel. Do you know how to do one? And the number of times that I get this, and nothing moves in the vagina is pretty remarkable. So they're doing the Kegel all in their face, and it's not doing one bit of good for their pelvic floor, right? So I just double check that they're doing it, because that's another real good way for me to talk them into physical therapy, right? I'm like, if I can tell them, oh, this is not moving at all, and I've got someone who can help you, that's a good way. And I'm looking for tenderness just to make sure that there's nothing weird contributing it to her. Almost always when she's laying down, I ask her to cough really hard, like she's got bronchitis. Be careful. I always have a Raytech, a little 4x4 gauze in my hand when I have them do that, or you will get sprayed. So you'll just be unexpected about the one who has really bad stress incontinence, and you'll walk out totally wet. But it's really easy if you have her cough laying down and she doesn't have much in her bladder and she's already got leaking, you know what your answer is. It's stress incontinence. And then we always worry just a little bit about neurologic stuff. So if you read any of the guidelines, this is the minimum that has to be done for a physical exam. They'll say a neurologic exam, but this isn't a complicated neurologic exam. If she can walk in, and if she doesn't have any weird abnormal sensation as you're doing your exam, she's intact neurologically. So it can just be a quick neurologic exam. It does not have to be the neurologist's version of a neurologic exam. So what about the diagnostic tests? Well, these are the minimums, again, when you read of anything, and I'll talk about this post-void residual because that's a hard one. But a urinalysis, so a quick urine dip, we're looking for infection, hematuria, glucosuria, right? That's a potent diuretic, so is it by chance totally undiagnosed? Diabetes, probably not. They've been seeing you. That's only when they come to my office that we miss the diabetes if we don't look at the urine. So just make sure that you've got that basic rule out done. And if there is any question about infection, remember, a urinalysis is really, really poor at differentiating infection. And the reflex to urine culture misses 20 to 25% of infections. So if you truly are questioning about infection, you need a urine culture. So that's just an aside. That's when I did my UTI talk, that was the big thing. Urine dips, urinalyses have no place in the evaluation of UTIs. And that's always, big eyes looking at me like, what? I mean, we've done that our whole lives. Again, I'll repeat it. Urinalyses, urine dips have no place in the workup of a UTI. She's either got symptoms and she's got it, or you have abnormal situation and you need to be doing a urine culture. But we could save a ton of money, and all of the guidelines say this, if we just quit doing the urine dips for UTIs. All right. Off of that and back to the urinary incontinence. So post-void residuals. Pretty much in primary care offices, I feel it's safe to say only if she is symptomatic. And remember, I told you that history's a little hard. You ask her if she's leaking. I mean, you ask her if she's emptying completely, and with urge incontinence, half the time they tell you no because they're sure going back to the bathroom so fast means they didn't get it all out the first time. So be careful about how you ask the question. I realize post-void residuals are not going to happen in your office. And don't send them to radiology for one, please. Like, don't go get an x-ray just to see if they're retaining. We can deal with it in gynecology offices really easily to determine if there's truly. The guidelines that say they always have to have a post-void residual is, I better not be doing surgery or any further intervention until I've ruled out retention. But if it's the first step in your offices, I just really think those guidelines are misleading about how important a PVR is. It's not worth financially sending them to radiology to get a post-void residual studied unless you've got a high suspicion. And then don't send them to radiology, just refer them and let us deal with let us just do the workup and figure out if they're retaining. And then what's normal is always super controversial, right? Everyone agrees less than 50 is normal, and everyone agrees greater than 200 is abnormal, but you can't get anyone to agree between 50 and 200. So it's really several measurements and kind of an overall picture that helps us gestalt if this bladder is truly not working. Voiding diaries. Again, I wouldn't expect you to do these in your offices, but I find them super helpful, and I make patients do them, and I make them measure urine output, and they are so insightful to me. I can usually figure out a bad historian simply based on a bladder diary. So, and then urodynamic studies, that's where we put the catheters in and do all of this testing, has really gone down in frequency of use. It was an expensive way to get a lot of money, and it doesn't have as much clinical impact as it probably should have. And so there's more and more situations in which our guidelines are saying there's no need for urodynamic studies. So just FYI to you. But in your office, make sure you get the urinalysis. Just make sure that you've ruled out infection. And if you strongly have a suspicion about infection, don't hesitate to order a urine culture. So let's talk about treatments. So again, remember I said urge and stress are treated differently. You've got to know what you're treating to start with this, although there is one quick give me, and that's that behavior modification works for both. So if you don't have time to figure out whether it's stress or urge, and she's willing to go to physical therapy, just send her. They'll figure it out. Like, they know what it is after just talking with them. So that's your one give me. You don't have to know what you're treating to know that physical therapy would help either one of them. And so physical therapy is not just Kegels. They're doing, in essence, kind of complete behavior modification. There is a wonderful physical therapy program here at Portland Prov. Your physical therapists are fabulous. And we're lucky in the greater Portland metro area in general that we have unusually good pelvic floor physical therapy available. And if they don't want to travel here and they're further away or further east, Therapeutic Associates has multiple offices that do physical therapy, also fabulous. And all of the major hospitals in town, Adventist, the Legacy System, the Providence System, all have really, really good physical therapists. So they're not going to do just Kegels with them. They're going to spend all the time doing the education that you don't have time to do. They're going to talk with them about how much they're drinking and get it back down to a normal volume. They're going to have the discussion about caffeine and tell them, if you drink that much caffeine, it's always going to, impact your bladder. They're going to talk with them about scheduled voiding, figuring out how to manage this, what the challenges are. They've got a little more time with them. So think about physical therapy as your way of getting behavior modification done. And they're going to lecture them about weight loss too, which is great to have it coming from more than one place, right? About the benefits of weight loss. There is good, I rarely have a patient complain about having gone to physical therapy. Almost all of them feel it was worth the time to go and money to go. So 50% improvement is kind of standard across the board, and some women do a lot better. So sometimes we have these first steps that we're supposed to do with the clinical guidelines, and it's never going to work, and they're just going to go on to the next thing. This one really works. I mean, a lot of women are really pretty happy with this. They don't want to be sent again if they've gone once before, so just make sure that you're not trying to talk her into going back. If they went once and it didn't work, they're not really interested in doing it again. But it is worth getting them there, and you don't have to do all of the discussion. Now, again, I still want you to think about a few things. Rule out the UTI. If she's on a diuretic, there's nothing the physical therapist can do to fight that diuretic. If you can get rid of it, try to, right, and see what you can do. And I'll throw in one other caveat there. If she is a diabetic with a hemoglobin A1C over 8, there's also no prayer of us fixing that incontinence. So just the diuretic, think about you're really out of control diabetic, and just know there's only so much we can do for those situations. But physical therapy works. And then the one other caveat I will say, though, is bring them back after physical therapy. So in all of the discussions we've done about studies we've done about urinary incontinence with women, they just figure there was nothing else, and they kind of fall off, and they assume the medical system can't help them. I mean, we're worried about other things. Urinary incontinence usually isn't on some regulatory measure or pay compensation that you're being measured about, right? And you're trying to get all of their, screening done and everything else. Incontinence isn't high there. It matters a lot to her, but it doesn't matter as much to us. And so weigh that. Remember that study that women think about, diagnoses or problems that would be worse than death? Incontinence is up there to them. So just kind of realize that's important to her and that we've got options and we should probably do it. So 80% feel that physical therapy was initially very helpful, but this is a progressive disease, and so almost always they progress on with time, and PT isn't just enough. Only 50% were satisfied after 1 year from physical therapy. So it buys time, and it's good, and it teaches them a lot of good things, but it doesn't last for forever. And again, change the things you can, stop the diuretics if possible. Let's talk about another one, sleep apnea. So sleep apnea is one of the main causes of getting up multiple times at night. And it is amazing what getting them on a CPAP machine does for their sleeping through the night with their urinary incontinence. And we think the mechanism is all through antidiuretic hormone. And so they just have this huge shifting of their urine output to the middle of the night. And treating sleep apnea really, really works for some of these women. So just remember that obesity, sleep apnea are kind of together. And address the chronic cough if you can. If she's just coughing and hacking away all the time and that causes her to leak, I mean, you know, some of those simple things that we could work on make a difference too. So let's talk now specifically about treatments of urge incontinence. We'll talk with that because that's the one that bugs her the most. So the first thing I do, and again, remember, physical therapy will do a lot of this for you, but it's helpful sometimes if you reinforce them. I tell them they have to go on a bladder detox diet. That's in vogue, right? Everyone's doing detox diets for their colon, detox diets for their gut, they're for anti-inflammatory diets. You tell them they do a detox diet for their bladder, now all of a sudden they're listening to you. And I tell them that they have to stop coffee, tea, carbonation, artificial sweeteners, and alcohol. 4 weeks. Nada, none, zip. And I have to emphasize that, and they look at me, none? Yes, none. Well, why 4 weeks? And I'm like, they're like, but I've been doing it for years. That can't be the cause. It's like, well, it didn't cause problems before, but newsflash, you know, you're getting older and now it does, right? And now we're having trouble. And that is a hard one. I would say even with my lecture, I am guessing, I wish like for nicotine, I had the ability to do a blood test and see if they really complied with my instructions about coffee. But with that lecture, I think I'm only getting most people to do a significant reduction. A significant reduction will work as well. But truly, the full detox for a whole month of nothing and then slowly adding back one at a time is the best way to deal with the irritants. And then usually they're converted. If they stopped everything and their whole problem went away, they're like, oh, now I know if I drink the coffee, I'm going to be in trouble. And then I say it's about quality of life. Decide if it's worth it that day. Right? And don't do it if you've got a really important thing at work that you've got to not be running out of the room for, right? It's just this awareness of what's doing it. We stop excessive fluids. That 60 to 80 ounces of liquid per day is all that's needed. And avoiding fluids for 3 to 4 hours going to bed. Everything they drink for 3 to 4 hours before they go to bed is going to come out in the middle of the night. It won't make it till the next morning after about 40 years old. So that's, deal with the constipation. Fiber and Miralax is almost always the right combo. Citracel causes a little less gas than Metamucil does, or Benefiber, but Benefiber goes on and off the market. But Citracel or Benefiber every day, a little Miralax every day, and that will do wonders for the vast majority of constipation and weight loss. So every kilogram loss, this doesn't have to be down to normal weight. Every kilogram lost resulted in a progressive 3% improvement. So they will get benefit from the weight loss long before they're down to a normal weight. So that kind of makes it a little easier to say weight loss might be a good thing to do. So that's the behavior modification. And again, how much you have time to discuss this is probably that much, right? You can just say, I'm just warning you, the physical therapist is going to take away your coffee when you go, and I agree with them, right? That might be all the education that you do. But physical therapy will go through all of this with them. So where are the pieces beyond that? Well, medications. It's many times that patients are fed up by the time they get to me, and so I'm doing behavior modification and starting medications right away. But these are not a panacea at all. So here's the frustrating piece. The antimuscarinics, oxybutynin, tolterodine, ditropan, detrol, trospium, darphenocin, phenysteridine, sulfenadine, Vesicare, Enablex are the brand names. So there's now significant concern with these that long-term they increase the risk of dementia. And many times they are being labeled with that. So I get the letter from the insurance company that denies me doing anything besides medications until I've done a trial of medications. And then the next letter I get from the insurance company is, oh, you place this patient on a medication and that's contraindicated in the senior age woman, and I want to scream. Like, I guess 2 departments at the insurance company don't know that they're sending me exactly the opposite instructions. But I do the short trial of the antimuscarinic, right? I usually start them on oxybutynin. It's generic. It's available. It doesn't usually matter even if you give them a year's supply. The statistics are staggering. Less than 80% of women continue these medications beyond 1 month. They don't like them. They don't like the side effects at all, and they really only give modest improvement. You have to do it as the first step for insurance companies, but know that this almost never works. Now, there is an occasional woman that's really, really happy with it. And in that case, I'm worried now about the long-term effects of an anticholinergic, these antimuscarinics, on the dementia risk. And so I start with the one her insurance company does. I document that she didn't like it and had, side effects that she didn't appreciate. Sometimes they make me do a second one. We go through the roll again. We do a second one, document that she didn't like it. And then I can usually get them onto a beta agonist, mirabegron or mirbetriq. It's not yet generic, but more and more insurance companies are covering it. It usually requires a prior authorization, but that's my goal, right? Is if I'm going to have them on something long-term, well, and who knows, maybe in 10 to 15 years we'll be sorry we had them all on Myrbetriq, because that'll have some long-term effect that we don't know. But it has rare side effects, and it can be used pretty safely, but I watch blood pressures. I just have them check a blood pressure. I say, the next time you go to your primary care office, just make sure that your blood pressure is okay. A very small percentage it will worsen their hypertension, and it'll be hard to control. But if I have to leave them, if they can't get Myrbetriq covered, then probably trospium may be best with the concerns about dementia. But again, it almost never matters. I can't get a woman to stay on these for years, almost ever. And you may think she's on it, and she's not taking it. She just doesn't tell you, because the discontinuation rates, they did these studies in Kaiser where they could see whether or not they picked up the prescriptions regardless of what the patient said. They don't go back and pick these up. They don't like them. So bottom line is, it's rarely the long-term solution, but you always have to try it first, because the insurance company will say you can't go on to anything else if you haven't tried these. So it's a little bit frustrating catch-22. But what else? Now, this is just stuff FYI for you, so you know that these are available, because the range of options for urge incontinence has dramatically improved over the last 5 to 10 years. We really can offer much more than we used to. And a lot of women never get to this because they give up and they quit telling us about it, and primary care doesn't know to refer them for it. So Botox injections, all of these work equally well. So I'm not picking one of these for women based on efficacy. They all work about 80% of the time. But in women who nothing else has worked for, 80% isn't so bad. Botox injections are an office procedure. We put the camera in, and we do injections in the back wall of the bladder of Botox. Often has to be repeated about every 3 to 6 months. It's just like the cosmetic stuff. It wears off. I do worry just a little bit with Botox, because there's about a 5% risk of retention, and then I got to deal with that retention until the Botox wears off. But most of the time the retention is tolerable even without intermittent self-catheterization. Like they're just kind of retaining a little, but it's not a big deal, and we just wait for the Botox to wear off. So Botox is an option. Women don't love that procedure. Well, they don't love any exam we do in gynecology or procedure we do in gynecology, but I can get women through that Botox in the office. I put lidocaine in their bladder before they go, and we can get them through it. So Botox is a potential option. Post-tibial nerve stimulation. So there's the whole field of neuromodulation is what's really changed in controlling urge incontinence. Remember, we're still talking about urge incontinence, the one that bugs them the most. If we place a little acupuncture needle behind the ankle in the post-tibial nerve region and stimulate that for 30 minutes with an electrical stim once a week for 12 weeks, it's the slow road, 80% of women will have marked improvement in their urge incontinence episodes. You can't quit doing nerve modulation, right? You have to go on and do that indefinitely. So they go on to once-a-month maintenance after that. There's almost no risk with it, right? I mean, it's a little discomfort in the ankle. Women love it because now we don't call it acupuncture, right? Because only neuromodulation is covered by insurance, but they're getting to come in and get acupuncture in the doctor's office, right? And then they have the chance to sit with my MA, who reminds them, how are you doing on drinking that coffee? And how many glasses of water are you drinking a day? And they come in with their big, huge thing, and they have the discussion about, So they're getting constant reinforcement from my medical assistants about what they should be doing behavior-wise as well. We usually don't see improvement until about 10 weeks. It's the slow road. But pretty consistently, 80% will have improvement. And it's great for my patients with a lot of medical comorbidity. And no retention. I don't have to worry about that risk of retention that I have with Botox. And finally, if they are healthy enough and really don't want to come into the office for that nerve stimulation, and the tibial nerve is a little more distal, we can place a nerve modulator right in at S3 in the sacrum. The therapy is called InterStim. There's multiple new ones coming on the market. But it's about as simple a procedure as placing a pacemaker, a cardiac pacemaker. We actually do them in the cath lab. We take them in and with radiologic guidance get a little lead into S3. And they go through a test phase to see if stimulating S3 works. This works right away because we're so close to the distribution. It's not this 10 weeks of waiting time. But we place that little electrode right next to the nerve, hook them up to that external generator. They do a week test phase. If they get improvement, then we go back in and we implant the generator in the buttocks, in the upper buttocks, and it's underneath the skin and just works every day. They become rapidly unaware of the stimulation. So most women describe it as a thumping or a tapping or a buzzing sensation that they feel vaginally, and within 30 to 60 minutes of increasing the amount, they're totally unaware of it again, and they just go about their life with this implant in, and they don't have to think about it. The one risk we worry about with that is infection, but otherwise pretty minimal, and I can usually do it with just propofol or less sedation if a woman is worried about it. So even with anesthesia risk, I can still get by with doing it. So just know that there are really, really good options beyond medications if a woman is having significant bother, and she gets to pick what sounds best to her. All of these work about the same. So, and some have very low, risks associated with them. So don't hesitate to refer on. Stress incontinence, no good medication options. A pessary can be tried, but they really don't work well. Unfortunately, really, if conservative physical therapy doesn't work, the next step is surgery. Let's talk just a little bit about the mesh. Gold standard first-line surgery is a mid-urethral sling with mesh. And I spend my entire life in the office explaining to women why what they see on TV is not the same as what I'm telling them about mesh. So here's the crux of the problem. The older surgeries had all the same risks: infection, chronic pain, debilitating nerve problems, and they were higher than it was with the mesh. There was just no mesh company to sue, right? So any other surgery I have to offer them has more risks than the mesh does. And it doesn't work as well, and it doesn't last as long. But again, there was no mesh company to sue, and so that's what we're stuck with. And yes, mesh has potential problems, but less problems than the older surgeries did. And it's just really frustrating because mid-urethral slings really are pretty impressive to get women through. 1 week off work. Most of my patients use 1 or 2 tablets of narcotics, and then they're fine with ibuprofen. If anything, they feel too good too fast, and I'm just warning them about doing excessive lifting until they're healed from the surgery. And 95% can give up their pads, and it lasts for 10 to 15 years. So what a tragedy that the mesh ads on TV are keeping as many women as they are from truly considering an option that's better than anything that used to be there. So that's just discouraging. So when to refer? Well, complicated history. You try the initial things and it doesn't work. If she had previous incontinence surgery, particularly if she wants it again, don't bother. Just refer her on. We can deal with her. And if you suspect that elevated post-void residual. So barriers to treatment still remain. Only about 25% of the time when it was indicated is a medication given in urge incontinence. The treatment failed a large percentage of the time, and then nothing is done after that treatment failure. It's just kind of like, oh, well, sorry, that didn't work. And a high percentage of women just go completely untreated at all because the timing is not good and you've got other things on the plate. So that's the end of the incontinence. And I had just a few slides about prolapse, but I am going to skip those and just take any questions that you have about, I just want to make sure there's nothing. I think just I'll just show you a quick picture of pessaries because I referenced that briefly. We use pessaries most often for prolapse, so holding up the falling down vagina. They sometimes are used for incontinence too, but they don't work very well. But there really are a huge range of options of pessaries, and women either love them or hate them. And so just the parting pearls: stop caffeine, tea, carbonation, alcohol, artificial sweeteners. Remind them they can't drink 8 ounces of glass a day. Stop diuretics, control diabetes, and prolapse does not cause incontinence. So are there any questions? And I'm just going to repeat your question to make sure it gets onto the recording. Yes?
How did they pick this posterior tibial nerve, and what's the physiology of that?
Okay, so the question is, how did they pick the posterior tibial nerve, and what's the physiology of that? Same distribution, same dermatome, S3, S4 pelvic floor. And it's accessible, so that's how the research got started with it. We've known for a while that nerve modulation makes a big difference for pelvic floor function. The interstim therapy has been around since the one implanting at S3 has been around since the late 1990s, but initially the procedure was super invasive. Like, we had to do back surgery. We did this cut down, placed it through S3, and now we do it all with radiologic guidance. So there's been a lot of work in the field of neuromodulation. This is what we think is the problem, that much of what's happening with urge incontinence to the bladder is mixed messages between the brain and the bladder. That the message, the going up to the brain is so loud of the bladder saying, I gotta go, I need to go, that the brain can't do anything but stop and listen to it, and then it inappropriately sends back down the message to go. And if we simply send large volume of different messages down that pathway, it starts wiping out all that ineffective messaging. And when it goes back to the bladder and tells the bladder really loud, like a different message, it's just noise, right? It stops the thing. I tell my patients it's a little bit like turning on and off the computer. Like, you know, if the computer's not working, you just stop it, reboot it, and it kind of cleans out all of the messages, and then it does better. It's like if we just clean out all of the messages on that nerve with excessive electrical stimulation, it works well. And I'll add the caveat I forgot to talk about it, but your question prompted me. Fecal incontinence. InterStim, the S3 implant, works amazing for fecal incontinence. In fact, it's now our first-line therapy rather than doing a sphincteroplasty, doing any surgery. 90 to 95% of fecal incontinence, regardless of type and reason, will respond to InterStim. So it's a huge improvement for fecal incontinence that we haven't had really good options for before. Yeah.
The idea of having little handheld stimulators, could that be applied to a patient? Have them show them where to apply it? You know, where the little e-stim?
Yeah. So the question is, those handheld e-stim devices. Could you teach a patient where to apply that and do post-tibial nerve stim? A lot of research happening in that area so far has not been successful. Like just doing external stimulation hasn't worked. That needle getting close to the nerve is what. But the newest therapies in this vein that they're working on is where you would do just a little implant. You would do a little incision on that skin, put that in for 6 to 8 weeks, and they would do their therapy at home with a remote that would stimulate the implant. So they're doing a lot of work at trying to figure out how to get this into the home. I have had some patients be successful with their acupuncturists if I explain where they need to go doing it, but we haven't yet been successful with external TENS units in this area.
The
question was, does it have a point name in Chinese medicine? It must. I don't know what it is, but when I describe to patients and give them and say, have your therapist go look at the YouTube about PTNS, some of them come back and they're very happy and successful with it. But it requires that electrical stim. And some acupuncturists do stim and some don't, and so it's been variable. But I've had people be very successful with their acupuncturist. Yes?
Modalities work in people that have had radiation?
So the question is, do these modalities work in people who've had radiation? And sometimes. So the challenge with pelvic radiation is that we will eventually develop radiation cystitis. And if it is a small, contracted, scarred bladder that no longer can stretch, once we've lost bladder compliance, most of these therapies don't work. But that's usually a delayed part of radiation cystitis. So we do all of this, and then sometimes we get to an end stage. When they're truly an end stage, contracted, no compliance bladder, the only solution at that point is diversion. They get a pouch, and we divert them from the bladder because it just won't function at all. But that's usually 10, 15 years out from radiation, so we go through all of this before, and it's almost always urge is their problem with radiation. They're having the same pathway of urge incontinence type symptoms. Any other questions? Yeah.
How about Hollywood Jade Rocks?
How about
Jade Rocks?
Hollywood Shade Rocks?
Jade. You haven't been watching the news lately.
Oh no, I missed 9/11 too because I got into work and I didn't know that we'd been hit because I didn't watch the news. I told my staff if we go to war, they have to tell me because I'll know it.
I'm blanking on has been selling jade eggs.
Jade eggs.
To put in the vagina for a multitude of
Oh,
reasons.
so there's all kinds of devices that go in the vagina to try and make the Kegel stronger. These weighted cones and these various things, and it's supposed to increase the pelvic floor health. They do far better at physical therapy with biofeedback, and it's cheaper usually. So yes, there is the concept of any device that helps you do a stronger Kegel, increase the pelvic floor muscle tone, will work better for holding tight the urethra when you get stress incontinence, and for urge incontinence. So part of the tricks they teach them with Kegels are what they call quick knacks. So when you get that urge and the bladder says, I gotta go, I need to want to go, if they contract the pelvic floor really fast and quick against the bladder, it kind of pokes it and says, knock it off, stop it, like you don't have to go right now. And so Kegels work both ways, right, for urge and stress incontinence. And so the theory is just with those devices, one, you can't hold an egg in if you're only doing the Kegel in your face. So it kind of helps women make sure they're using the right muscle. And does it really make it that much stronger? The data's been slow. But again, I just get them to physical therapy. I'm like, just go do 1 or 2 visits with them. Even if you won't go through their 4 to 6, you'll get a lot out of it. And most women are thrilled, and then they stay for the 4 to 6 visits. And if they truly need biofeedback or weighted cones, the physical therapists are really good about helping the patient that might benefit from that decide whether or not to buy it. But there's a lot of hype about it that's not near as exciting as it sounds. Yes?
You made it sound pretty certain that the mesh suspension has a deadline when it stops working. I think you said 15 years. Why exactly is that? And I'm under the impression that a redo is significantly more complicated. Is that wrong?
Yeah, so good question. The talking about that mesh suspensions for the incontinence, the sling for incontinence, has a limited life efficacy. And then the question was, and aren't the redos pretty complicated? So from our old surgeries, birch urethropexies, fascial slings, they also too had a limited life efficacy, usually less than the mesh slings. So we've always had recurrence, known risk with these. That a redo is complicated was true of the old surgeries, but the statistics are remarkable with mid-urethral slings about how easy and efficacious a repeat procedure is. So the mesh has been out long enough now that I see back a lot of patients, and 10 to 15 years is the average, right? Occasionally I see back a woman younger, sooner that has trouble with recurrence. If she gains a lot of weight, if she has something else happen, a chronic cough or whatever, she might be back sooner. If she smokes, smoking decreases significantly the length of efficacy. In fact, Oregon Health Authority, the OHP, no longer will cover a mid-urethral sling until she's proven with blood tests she's not smoking. Yeah, but repeat, 10 to 15 years is usually what we get. The efficacy only drops by about 5% in repeat mid-urethral slings of efficacious the next time, and it's no more morbid to get them through the procedure.
Procedure doesn't.
Oh, and so the question is, what's happening anatomically that the first procedure doesn't work? So it's an example where the brand name is commonly used to refer to the incontinence procedure. So the first one that came out on the market was called the tension-free vaginal tape. That's the brand name from Gynecare. We refer to many of them that way. You'll hear women say, oh, I had a TVT, right? And they may or may not have had that brand version of it. They're all very similar in concept. It's tension-free. It's a sling that's going underneath the urethra, right? So when they sneeze, cough, laugh, they can push shut their urethra against it. But it gets its strength by her scar tissue growing through the the interstices of the mesh. And with time, everything sags south and loosens up and becomes slightly less supportive, and it just no longer is able to provide that same firm backstop against which the urethra can contract. But because it's not hooked to any bone, it's not hooked to any fixation point that doesn't move, as that tissue kind of becomes weaker, lax, sags a little bit more, that's why we lose the efficacy at 10 to 15 years. Yeah?
Therapeutic like vaginal estrogen, estradiol, would that make a difference in this particular use of the sling?
Oh, and so the question is, would vaginal estradiol make a difference in the use of the sling? And interestingly, no. So we, for a long time, have thought you got to get every woman who's had mesh anywhere near her vagina onto estrogen so that she doesn't have little, erosions as the vaginal skin thins out. And the new research is suggesting it might be absolutely opposite. that healing is delayed. So post-hysterectomy, post these incontinence slings, we actually don't want estrogen in there during the healing phase, is what the new research is suggesting, that it actually changes the way the scar matrix is coming together. So the main advantage of estrogen in the whole incontinence story is urge incontinence. If she's got bad vaginal atrophy, atrophic vaginitis, treating that makes the bladder, which is next door, happier. And there's probably some receptors in the bladder that might be responding as well. But stress incontinence, not much. Post-op, the new data is suggesting might actually not be good at all. And so estrogen's always been this complicated story.
What about
Yeah.
post-op, but let's say, she's out of
Well, that post-op stuff is making us question. So we don't know, truthfully, about the long term because there's so many confounding variables too when you start doing that, and how much did she really use, and how often was she on it versus someone who wasn't, and then obesity plays in because all the fat cells make estrogen, and then how much is coming from what, and so long term it's really hard for us to know the answer to that, but we are becoming less enamored with vaginal estrogen for post-op mesh than we have been, but that tide is just barely turning. So you'll still see a lot of people using it because the research is just kind of new, trying to figure out what it means, but I'm not trying to argue a woman into vaginal estrogen anymore. If she was on it, I don't maybe make her stop it, but I definitely stop it for a few weeks right after surgery, and I'm not trying to cheerlead her into using vaginal estrogen for the rest of her life because I really don't have good evidence about it and it's expensive. Any other questions? Great, thank you so much.